coming in this nasty weather outside, or wonderful weather, depending on your perspective. Okay, I'm going to be talking today about a method for achieving covariate balance in cluster randomized trials. And this came directly from a need to address this problem in our own research. Okay, so just to go over the things that we will cover in general today, we'll look first of all at a brief background on why do we want to do cluster randomized trials in the first place. Why do we need to randomize clusters instead of individuals? We'll also look at some examples of what can go wrong. And then next, a common way to address these kinds of problems is to use stratification, and that works well up to a point, but has some limitations. So we'll talk about that. And then I want to introduce a covariate constrained randomization procedure. And finally, look at some examples of two trials that where we have actually used this already. And we have several in the works that we're beginning to use it, and it has worked well. Okay, cluster randomized trials. In cluster randomized trials, the unit of randomization is a group rather than an individual. And groups can be defined in a lot of different ways. Often groups are communities, counties. In the educational setting, they can be classrooms or schools. They can be hospitals, medical practices, or even families. So why do we do this? Just briefly, there are a few key reasons. One of the most important is that sometimes the intervention itself is actually at the level of the group. And a couple of examples would be, say, an educational campaign to increase colorectal cancer screening in rural practices, in rural communities, quality improvement initiatives that are directed at a medical practice rather than directly at patients or individuals are another good example. Another reason for doing cluster randomized trials often involves contamination. Even in a situation where the intervention is targeted to an individual, often in a primary care practice setting, there's spillovers, so that there's potential contamination to other individuals in the practice. Feasibility sometimes is a good reason for doing cluster randomized trials, sometimes economic considerations. We run into situations in practice-based research where physicians are sometimes not willing to deliver an intervention to some of their patients and not all of their patients. And I think that happens in communities as well. So there are a number of good reasons why we end up having to use cluster randomized rather than individually randomized trials. There are also issues. There are complexities with these designs. Generally, the number of groups to be randomized is much smaller. There's heterogeneity among the groups, but often individuals within the groups are more similar to each other than individuals who are members of other groups. Simple or even stratified randomization, when you've got a fairly small number of units, can result in study arms that tend to be very different from each other. And I'm going to give a couple of examples of where this has actually happened. And finally, these trials require more complex analyses, and I'm not addressing that here, but they tend to take more than patient randomized trials. So, cluster randomization, what can go wrong? I have a couple of key examples. This one is one of the earlier cluster randomized trials that was done in the UK, and the unit of randomization was a GP, general practice, medical practice. And There were two arms. One arm was randomized to cancer screening for breast cancer, and the other was a control arm. Now, a key issue here is that at the time of randomization, there were no data available on patient characteristics in those practices. And specifically in this case, there was an issue around socioeconomic level. But there was little that could be done because the researchers didn't have the data on socioeconomic levels of the practices. Well, as it turned out, using a simple randomization procedure, screening practices have poorer socioeconomic levels than controls. And as a result of that, the crude estimates of treatment effects differed considerably from the adjusted estimates. And the authors of this study recommended stratified approaches. Okay. Now, example 2 is a study that we're just now completing, an NIDDK-funded study to compare 3 approaches to implementing the chronic care model in primary care practices with the goal of improving diabetes care. Randomization was at the practice level. We used a stratified approach. There were not complete cells across all the characteristics that we wanted to use for stratification, but basically grouped practices with similar characteristics in terms of whether they were rural or urban, practice size, and then community health center versus private. And then within these groups, they were randomized. This occurred in 3 ways. One study arm only was included in 2 ways for funding reasons. And once again, at the time of randomization, at the time this study was initiated, there were no data on diabetes process of care, which was the primary outcome, and limited data on patient characteristics. So stratification was the best that we could do at that time. So if you take a look at this, the baseline characteristics across these 3 study arms, using this kind of stratified approach, several of the baseline characteristics differed significantly across the study arms. And the one that had the most impact here was this baseline diabetes process of care, which was higher in study arm 1 than in study arms 2 and 3. And thus, there was less room for improvement in this trial, in that study arm. And whether it affected the outcome, we don't know. It's a study limitation. Okay, so covariate imbalance in randomized trials isn't a new problem. Minimization methods were described even as early as in the 1960s and later extended to cluster randomized trials. There's a key paper by Raab and Butcher in 2001, looking at the effects of covariate imbalance on a key optimal design criterion, and that's the difference between the crude and adjusted treatment effect estimates. And they showed that differences between crude and adjusted treatment effects are minimized when the differences in the treatment group means on covariates are small. And they suggest an actually fairly simple procedure for achieving balance. To date, however, there have only been relatively few cluster randomized trials to actually use these kinds of procedures, at least in the literature. I think part of the issue is having data at the time of randomization. So, now I want to describe the procedure of covariate constrained randomization. And key, once again, first of all, you have to have baseline data on units of randomization. And then once you have that, the procedure itself is fairly simple. In step 1, you generate all possible randomizations of units into study groups. Step 2, create a balance criterion, and the balance criterion is defined as the sum of squared differences between study groups on relevant standardized variables. And you do that for every randomization. So you're comparing for each possible randomization, you're getting group means and looking at the differences, estimating the difference in the group means on those particular variables. So here, let me see if I can work this pointer. Okay, yeah, there it is, okay. X1 sub 1 represents the mean for study group 1 on variable 1. X21 represents the mean for study group 2 on variable 1. That's squared. W is a weight. So there is the possibility of differential weighting of variables if you think some are more important, and so on. The third step is to establish a criterion for the maximum allowable difference between the study groups and define a set of acceptable randomizations. In the literature, the few that have been done, most have used approximately the best 10%, and that's what we did. There's no hard and fast rule, and I'll talk about that a little bit in a minute. But the ones that I have seen have used the top 10%. And then once you've got this acceptable set of possible randomizations, you simply randomly select a single randomization from that and assign your study groups. And that's it. There is a program available that you can check the references and you'll see where to find it. But we found that it was easier to write our own than to try to adapt a program because every study is different. So we ended up writing our own program to do this. Okay, so study 1. And this is one of the CRISP studies, one of the 3 studies that Elaine mentioned. And study 1 compares, the intention of study 1 is to compare 2 reminder recall approaches to increase up-to-date immunization rates in 19 to 35-month-old children in Colorado. The unit of randomization for this study is the county. The variables that we chose for randomization are county-level data, and most of these are census data. Some come from the state immunization registry. And it included the number of children in that age group in each of these counties, the percent who are up to date on immunizations, pardon me, the percent who are actually in the Colorado Immunization Registry. Then we had some socio-demographic data in there, percent Black, percent Hispanic, average income of the county, and the ratio of pediatric to family medicine practices in the county, and then finally the number of community health centers in the county. So we had 16 counties in Colorado, and before carrying out this procedure, we actually stratified by rural and urban locations. So we did the randomization procedure within the rural counties and then within the urban counties. And just so you'll get some context, here's a list of the actual counties in the study for you to take a look at. So you can see they're really very diverse, and you could end up at just using simple randomization approaches with something that was very, very imbalanced. So let's see how it worked. Okay, baseline data. On average, we had 85 to 90% in CIIS, which is the Colorado Immunization Registry. There was a range to that. Number of children in the various counties, there was a huge range. in the population and the number of children who would be potentially eligible. Up-to-date rates also. There was a huge range. In rural counties, up-to-date rates ranged from 27 to 49%. In urban counties, from 29 to 54%. Percent Hispanic, there was a pretty big range there. Percent Black, less so. Average income, once again, an important SES indicator, very large range in terms of SES for the various counties. Pediatric to family medicine ratio, somewhat, but that ended up being a less important characteristic. And the number of CHCs, there was some differences there. Okay, so within the rural and urban strata, we generated all possible randomizations, and we used SAS Proc IML to do that. And we let order matter, but rather than deciding order, we just went ahead and allowed duplicates of randomization groups, but one with one group first and the second with the other group first. And that worked well. So we had 70 possible combinations of 8 counties into 2 groups. Then the next step was to standardize all these randomization variables. Now, the easiest way to do that and the fastest way for just our initial try at this was to simply compute z-scores. And that's something we can think about in the future, but that's what we did for these 2 studies that I'm going to talk about here. And then next, we calculated group means for each group for each of those 70 possible randomizations. And for each randomization, calculated the balance criterion, and you can see how we did that. And we chose in this study and in the next one to allow all these variables to be weighted equally. Okay, so once we computed the balance criterion, we examined the distribution of the balance criterion and selected within the urban a value of 1.4 as the acceptable set, which turned out to be slightly less than 10% because there was a gap in the distribution at that point. And in rural, 2.0, so that was slightly more than 10%. And then we wanted to go back and see how well this worked. So in order to do that, we compared the differences in means on the raw variables for the acceptable set of randomizations to the others. So this is the distribution of the balance criterion. And on top, let's see if I can get, okay, for rural counties, now these are completely partitioned. So down at the bottom, we have the acceptable set, and at the top, we have the rest of them. And as you can see, you could get highly imbalanced study groups if you just did a simple randomization. And the same with the urban counties. If I can get this, I don't know where it's going. There it is. There it is. Okay, in the urban counties, it's the same thing. Just by chance, you could get some really bad randomizations where the study arms were highly imbalanced. But this is the acceptable set in the urban counties. So you can see you're going to have a fairly balanced design, a fairly balanced study group. Okay? So let's see how it turned out. In order to do that, we computed the magnitude of group mean differences on all the raw variables, which I took the absolute value because obviously if you've got some positive, some negative, they're going to cancel each other out. And then I also wanted to look at the minimum and maximum differences on each of these variables to just give us an idea of the spread. So percent CIIS, clearly it was better in the optimal randomizations, but not significantly better. Now, we were constrained, so the maximum difference was only 7% in the optimal randomizations, and it could have gone all the way up to 13% if you were unlucky in the remainder. Number of children ages 19 to 35 months. This was significantly improved in the optimal randomization set. The maximum difference in mean number of children per county in the optimal randomization set was 171, where it was 704 in the other randomizations. This is for rural counties. Up-to-date baseline. At baseline, once again, we improved our chances of having a balanced study arms significantly in the optimal randomization group. The maximum difference was 3.3 in the optimal randomization group, and it was as high as 9.3 in the others. Not so much for percent Hispanic, percent Black. Average income, there was a huge difference. In the optimal randomization group, the maximum difference was $2,378 for average income, whereas in the other randomization group, it could have been as high as $27,000 different, which is huge. Number of CHCs also were more constrained in the optimal randomization group. Now, in the urban counties, we actually had greater differences on more variables there. Percent CIIS, number of children in the counties, percent up to date at baseline, percent Hispanic, percent Black, and average income were all significantly better in the optimal randomizations. Okay? Now, the selected randomization, so from that set of optimal randomizations, we just randomly selected one using a random number generator, and this is what we ended up with. So you'll see across the raw variables, it's fairly balanced in terms of group characteristics. Give you a moment to take a look at that. Okay? Now going on, so the next study where we has used this method had to do with immunization in obstetric and gynecology practices in Colorado. And we are testing an intervention for increasing immunization rates among eligible adult women seen in OB-GYN practices. We have intervention and control practices. The unit of randomization here is the practice. The variables that we selected for randomization, now in this case, we selected rural-urban and included it as a randomization variable. The number of FTE clinicians in the practice, the number of deliveries per month, the percent Medicaid, and then we had some immunization scores that were calculated for each practice that addressed their current immunization practices, because we wanted the groups to be very, very balanced with regard to what they were doing at baseline in terms of immunization. And we had a score for Tdap, one for HPV, one for flu, and then there was an overall score. So there were 12 practices in Colorado, and we required that the study arms be completely balanced by urban and rural locations. So we only wanted randomizations that included 4 rural and 8 urban practices divided into 2. So we needed 2 rural and 4 urban in each group. And baseline data, so you can see, once again, there's quite a bit of variability in terms of the practices. FTE physicians range from 2 to 19. Number of deliveries, there was a huge difference there, from 12 to 125. Percent Medicaid, huge difference there, 3 to 42. These scores, in and of themselves, it don't have meaning without an anchor point, but relatively they do. So, you know, pretty good difference in immunization scores that reflected what they were doing at baseline. Okay. Now, once again, going through the method. So we included rural-urban as a dummy variable, coded variable in the randomization scheme. So we ended up with 924 possible combinations of 12 practices into 2 groups. And we only considered randomizations that balance the urban and rural practices in the group. So that got us down to 420 randomizations with exactly 2 rural and 4 urban. And that worked just fine doing it that way, to actually include the stratification variable in with the randomization procedure. Then, once again, we standardized all the randomization variables. We just simply created z-scores, created a file with group means for each randomization, and computed the balance criterion once again. We, again, weighted our variables equally. Okay? So the next step, again, is to examine the distribution of the balance criterion and to set a target. And once again, we wanted to choose approximately the best 10%. And then compare differences on the raw variables for the acceptable set versus the other to see how well it worked. And so here we have, again, the distribution of the balance criterion, and you can see what could happen if you were unlucky and you got a bad randomization just by chance. You could have ended up with extremely unbalanced study arms. But the acceptable group is down here, and any one of them would have been just fine. So comparing the optimal randomization set to the remainder, number of FTEs, you can see a fairly good sized difference in the range there, going up to 2.7 in the optimal group and 4.6 in the other group. Number of deliveries, the maximum difference was 19 in the optimal group, all the way up to 42 in the remainder. Percent Medicaid, again, vastly improved, I think. 7.3 maximum difference in the optimal group, 19.7 in the other, and so on. And down to the overall immunization score, which was very, very important to us. A maximum difference of 2.3 in the optimal group and as high as 8.9 in the other group. So tremendous improvement in what could have happened by using this procedure and limiting the set of possible randomizations. And now, just to summarize, so we tried this on 2 studies, and we have 2 more lined up that we're going to be doing in the very near future. We're working on improving our SAS program and making it a little more streamlined, but again, every study is different, so it may not be possible to completely standardize it. These covariate constrained randomization procedures seem to be useful. They seem to be relatively easy to carry out. There's some hours involved, but it works. Preliminary data on the key variables is absolutely necessary. And the other thing I want to mention is that selection of the key variables is really, really important. So you want to think up front, what are the features of your study groups that are most likely to affect implementation of your intervention, uptake, that sort of thing, and be sure to include those. Stratification can be incorporated into the procedure, or you can do it separately within strata and then combine at the end. And then one of the things that we've noticed and would like to do some further exploration about has to do with the underlying distributions, the number of units, and how that affects how well this approach works. Okay. And I have a set of references. I think there's some handouts there, so you can go through those and see where this has been used some, and go back into some of the early descriptions and some of the later descriptions of who's used this. And that's it. Questions? How do we stop the... Okay, okay. Okay, yes, Patrick.
Did you get my fuse out?